Good evening, everyone. Welcome to our webinar. So thank you for joining us for today's webinar. My name is Rami Khattar, and I am the Quality Manager with the DHA at MENA region. When medical professionals apply the most up-to-date evidence-based treatment guidelines, patient outcomes definitely will improve. That's the simple truth behind the drive for continuous quality improvement. Our comprehensive suite of programs can help you advance farther and faster in the quest for ever better care. Today, we are presenting Putting Knowledge to Practice, Get with the Guidelines, Coronary Artery Disease, and the Chest Pain Center Certification by distinguished speakers. If you have any question during the presentation, please type them into the Q&A box, and we will bring them during the Q&A session. Before we start, I would like to express my sincere gratitude to our speakers, definitely, and to our colleagues from the National Center Dallas, especially Mrs. Pooja Patel, the Director of International Quality and Accreditation, and Mrs. Louise Morgan, the International Quality Improvement Director, as well to my colleagues in the MENA region, Mrs. Zahra Al-Hilali, the Regional Director for the MENA, Muhammad, Khalid, Druba, Haytham, and Donna for their continuous help and support. Now, without further delay, we will turn the time over to our speakers, but allow me to introduce them before we start. Dr. Alice Jacobs, she is a professor of medicine at Boston University School of Medicine, vice chair of clinical affairs in the Department of Medicine at Boston University Medical Center, and maintains an active clinical practice. She is the immediate past chair of the American Heart Association Get with the Guidelines Coronary Artery Disease Advisory Working Group and chair of the AHA Healthcare Certification Science Committee. She led the American Heart Association's Mission Lifeline, a community-based national initiative, and she served as a president of the AHA in 2004 and 5, and as a president of the Association of University Cardiologists in 2011. Mrs. Lonnie Den, Senior Manager Quality Improvement at American Heart Association. She has been a cardiac nurse for 35 years, serving in a variety of settings, including ICU, PICU, and many other departments. She launched the STEMI and the Stroke Outreach Program for a multi-hospital system in the Austin, Texas region. She received her Bachelor of Science in Nursing degree from the University of Iowa. And Mrs. Lori Hollowell, next slide, Khalid, please. So she's the American Heart Association Senior Manager of Quality Improvement with a subject matter expertise focus on the Mission Lifeline and Get with the Guidelines Coronary Artery Disease programs, registered nurse with a master's in Health Information Technology. Her pre-AHA experience includes flight nurse, emergency department, national registry paramedic, and volunteers as a firefighter. Mr. Muhammad Limzayan, he is an associate program manager with the American Heart Association at MENA region. He has a master's degree in health services management from Royal College of Surgeons in Ireland with Yarmouk University, bachelor degree in nursing as well from Jordan University, and he has many years of experience as AHA instructor and faculty, and served as a head of nursing education in different hospitals in Saudi Arabia and Jordan, and he was working as official ATLS coordinator, and he is an ATCN instructor as well. So now we will start our first topic with Dr. Alice. Dr. Alice, the mic is yours.
Thanks very much. Thank you for the introduction. I would like, on behalf of the AHA, I would like to add my welcome to all of you to this webinar, Evolution of Heart Attack Systems of Care. And I'm really delighted to have the opportunity to share with you our journey across Mission Lifeline as we develop STEMI systems of care for our patients. AHA's mission is shown on this slide. It's to be a relentless force for a world of longer, healthier lives. And this mission really fuels and informs all of the work of the Heart Association, including STEMI systems of care and heart attack certification. And you know, the AHA is forever aware, like all of you, that heart attack and stroke are the leading causes of death globally. Here are some of the statistics that we live with and that we're aware of. So each year, in terms of acute myocardial infarction, each year an estimated 785,000 Americans will have their first heart attack. And each year an estimated 470,000 Americans will have another heart attack. Every 25 seconds, an American will have a coronary event, and every 39 seconds, someone dies from heart disease and stroke. Next slide, please. So the why of heart attack, against that background on those very sobering statistics, the why of heart attack systems of care is shown on this slide. So this is 6 randomized trial, the pooled analysis by Zwoli and colleagues, and you can see the dates, 1994 to 2001. And it shows us that it compares mortality at 1 year for heart attack patients, STEMI patients, compared to their symptoms to balloon inflation. We speak, and as all of you know, about door to balloon time or achieving reperfusion when we inflate the balloon and the flow is restored, but it's really symptom onset. It's really the total ischemic time that we try to target. And although it's easier to measure door to balloon time because it's a little bit more accurate, it's the total ischemic time that really is our target. And that's really how Mission Lifeline is based. And you'll see that in the next few slides. So shown here, the relative risk for every 30-minute delay of presentation or to balloon inflation, you have a relative risk of 1.08, such that mortality is increased at 1 year by 7.5% for each 30-minute delay. Next slide, please. And when we started thinking about this and putting all these data together and worrying about them, we knew then, and this was the reality of reperfusion therapy in 2003, 2004, when we started thinking about STEMI systems of care, that 30% of patients did not receive reperfusion therapy, even in the absence of contraindications. And we knew then it was life-saving, both fibrinolytic therapy and primary PCI. The time to treatment of our patients within guideline recommendations occurred only in a minority of patients. Primary PCI was the preferred reperfusion strategy if you could do it efficiently, but we had 5,000 acute care hospitals and only 1,300 had cath labs. And we knew that the transfer time to PCI hospitals was unacceptably long, as shown in the next slide. So these data are from one of our national myocardial infarction registries, and it shows you the door to balloon time within 90 minutes, our guideline goal by transfer status. And on the top line, if you presented directly to a hospital that offered PCI, by 2004, only 41% of patients were treated within our goal of 90 minutes. And if you had to be transferred from a community hospital or a hospital that didn't provide PCI to a PCI center, only 5.4% achieved that goal. So what did we do? We launched Mission Lifeline, which is the American Heart Association's national initiative. And I focus on national, but it's really community-based. We were very cognizant of each community and what was different in each community according to their resources, their legislation, their regulation. And it was to advance the systems of care for patients with ST segment elevation, myocardial infarction, STEMI, and ultimately also, because of the commonalities, now includes out-of-hospital cardiac arrest and stroke. And the overarching goal of the initiative was to reduce mortality and morbidity for STEMI and the other time-sensitive cardiovascular disorders and improve the overall quality of care. And this is the system goals. You know, it's very patient-centric. The implementing the ideal system of care starts with the patient, so helping the patient to receive timely life-saving care, bringing healthcare resources together, and I can't emphasize that enough. We have to work together in the system, not in silos, creating a strong and efficient synergistic system. We define the roles of all of the stakeholders, all of those who are involved in the patient STEMI system of care across the continuum of care. We want to improve the overall quality of care through guideline implementation, save lives, and preserve the quality of life. So what is the Mission Lifeline system of care? This slide depicts, again, very important. It's not about only door to balloon time. It's the continuum of care, and it's what starts with the patient's entry into the system. So the patient can enter, hopefully through EMS by calling 911 and go to the STEMI receiving center. And this has a lot of, excuse me, different names. This is the PCI capable hospital or the comprehensive chest pain center. It also takes the patient to the referring hospital. That's the non-PCI or the primary chest pain center, and how we interact and collaborate. So it really depicts the patient's relationship with all of the components of STEMI system of care. And they can enter the system via 911, hopefully. We're working to achieve that. Or some patients take themselves to either hospital as well. And again, it's important when we see the patient's interaction with all of the components of the system that we act in a regionalized fashion. So we want to regionalize care and have standard protocols, pre-hospital activation, transfer of PCI. We want to make this as automated and as efficient as we can. We want to have standardized training, comprehensive feedback, and Mission Lifeline regional report participation. We have to constantly look at the data. We have to collect the data, look at the data, analyze the data, and then see what's going well and see what we need to improve in a continuous fashion. And here is the ideal system of care. So it's strong multidisciplinary teams, continuous relationship building, EMS transport destination protocols that the region agrees to. EMS is a very important player in this system of care. It's get with the guidelines, CAD data collection and data sharing critical. That's really the foundation. Process improvement activities to meet our guidelines, collaborative education, data feedback loops, and then to really drive performance, Mission Lifeline recognition and heart attack certification. That's the ideal system. So here is the evolution in terms of the data collection and reporting of the Mission Lifeline initiative. Mission Lifeline was launched in 2007, and I would take you back 1 year to 2006 when we convened a conference in Boston, and we had all of the stakeholders involved in STEMI systems of care. We had the community hospitals, the referring hospitals, and we had the receiving hospitals, and we had all of the physicians, not just cardiologists, but EMS. And we had all of the EMS organizations and the ED physicians and the outcomes experts and policymakers. And we charged the experts with defining the current system of care, designing the ideal system of care, looking at the gaps and barriers between them, and then coming out with recommendations for policy and research and programs. And we published our findings in a compendium 1 year later. And we promised ourselves, and AHA lived up to this promise, that we wouldn't just have a publication, but we would actually act on the recommendations. And so AHA did. By 2010, STEMI Receiving Center, we had STEMI Receiving Center, Mission Lifeline reports and recognition. By 2012, we had Mission Lifeline STEMI Referring Hospital and regional reports available. In 2013, the EMS community approached AHA and said, can we participate? Can we participate in recognition? And that's been an extremely successful program. In 2017, we relaunched Get With The Guidelines CAD. So we have a new platform now. And the advantage of this is that we own it and we control it and it's updated and we can be much more granular. So not only do we look at door-to-balloon times and do we look at transfer times, but we can also look at things as how many patients have an EKG when they get to the hospital within 10 minutes. Once EMS has an EKG on site, how long does it take them to pre-activate the cath lab? How long does it take them to call the ED? We can be that granular to look at all of the components to continuously improve the quality of care and the outcomes. And then in 2018, we relaunched the Mission Lifeline regional reports. Next slide, please. And here is the implementation of regional STEMI systems. All STEMI receiving centers are identified and involved. All STEMI referring hospitals are also involved. There's a regional consensus and a STEMI plan, so we all agree upon it. And these are perhaps even competing institutions, but they all sit down at the table together for the greater good. And AHA has been wonderful, and really with their brands and their reputation is the convener of these different factions, and it's been extremely successful in our country so far. Regional AHA quality staff engagement, they're the neutral implementer, very, very important role. Education in the community, the provider and the patient, quality metrics and regional goals, continuously looking at these and improving them. And then the data, a common data source and a mechanism for analysis and feedback, which fuels the system. So where are we now? So on this slide is a list of some of our progress, if you will. So we have improved the quality of care for patients with STEMI. We've increased the use of reperfusion. I can remind you that when we started this, 30% of patients didn't receive any reperfusion therapy. Now in Mission Lifeline hospitals, that's less than 1%. We've decreased the time to reperfusion, both in the pre-hospital space and as at the door. We've improved mortality when cardiac arrest patients are removed. The advantage now is we actually serve more complex patients with higher acuity, such as cardiac arrest patients. Now they can get to the hospital because we have these systems of care. So we have to really, the mortality is a bit confounded by that, but when you remove them, we've actually improved mortality as well. We've decreased door to balloon times, increased first medical contact to PCI, and you can see the door in, door out times. So we feel good and accomplished about our progress, but we are forever humbled by the work that's left to be done and the challenge to sustaining our progress. And I will share some of that with you. So just as a background, so you can see just some of the data that I'll show you on a couple of slides, is these are the N, if you will. So this is STEMI patients, the direct presenters, and you can see from 2012 through 2020. And again, when we relaunched in 2017, the numbers go down, and the 2020 numbers are a little bit lower because they're not complete. But this is the number of patients that in the hospitals that have participated in Mission Lifeline, so you have a sense of what our N is. And on the next slide, you can see some of the progress. So this is from 2010 to 2020 at the STEMI receiving centers. This is door to balloon time within the goal of 90 minutes compared to EMS first medical contact to device within 90 minutes. So we know even at the outset, door to balloon time, we were doing fairly well. It was in the 90th percent for when you get to the door to the balloon inflation. But now a systems approach and having the American Heart Association in the pre-hospital space, if you will, working with EMS, the goal in our guidelines now is first medical contact to balloon inflation of 90 minutes. And you can see we've made progress through the years. We're a little bit of a plateau, and we're looking through recognition and certification to move the needle, but we're still at 77, 80%. So we have room to still improve to get to the 90%, just like door to balloon time. The next slide shows the door in, door out. This is definitely a challenge for us, getting the patient in the referral center to have the stretcher stay there or to call EMS when we decide that we are transferring the patient to a PCI center. In some places when we started, it wasn't a 911 mechanism, it was the next available ambulance. So this has been a challenge, but you can see again, door in, door out, we've made progress. These are the median times. Our goal is 30 to 45 minutes. But we're on the right track, and we can really have a big focus on this at the present time. And what are our opportunities? And they abound. So this is for direct presenters, if you will. So this is to the STEMI center, the PCI center, EMS first medical contact to 12-lead ECG acquisition time, 12-lead ECG acquisition time to hospital notification. Once you have the ECG, how long till you notify the hospital that you're coming, the hospital notification by EMS to activate the cath lab. Can we bypass the cath lab in some of these hospitals with the right type of patient? Decrease ED length of stay once you get the patient to the PCI center. We improve feedback loops, offer more education, and increase EMS engagement activities. So shown here are the percent of pre-hospital cath lab activation. This is patients with STEMI identified by EMS and notification to the ED prior to arrival. We are able to look at this now to really get this granular in our STEMI systems of care to make improvements. And you can see from 2017 to 2020, 70% or so, we do it, but we're not making progress here. And so we have room for improvement. And these are the kind of things that we're focusing on. In terms of the referral hospital, if you will, this is arrival at referring hospital to 12-lead ECG acquisition within 10 minutes. 12-lead ECG acquisition to call for transport. So you know you have your STEMI, you know you want to transfer the patient. How long till you call for transport? Transport team arrival to patient departure from the referring hospital. We now have a goal of 15 minutes. And the overall door in and door out improvement. And we have challenges out in the field for door in and door out now. And so this shows you the percent arrival to 12-lead ECG within 10 minutes. These are all our facilities actually. And while it's 70 or 75%, 25% of patients do not have an ECG within 10 minutes. We know we have room for improvement. And the next slide shows the percent of STEMI positive 12-lead ECG to the time of interfacility transport call within 10 minutes. That's our goal. Less than 50%. So again, we are looking at this. We have the ability with our data systems to really focus on these type of things, and we know where we have to focus our efforts to make additional improvement. And then the heart attack certification link, the advantages, you have AHA staff with systems of care implementation and improvement expertise, and they're available to support quality and process improvement efforts and certification preparation. So I am a very longstanding and committed AHA volunteer, but I will be the first to tell you that it's our AHA staff, it's the feet on the street, it's their commitment and their expertise in the field, helping our hospitals and our customers and our patients and their families really understand the importance of this. They're an enormous resource, and much of our success is attributed to our AHA field staff. They promote patient-centric ideal systems of STEMI care. Our certification link aids in convening local, regional, and state healthcare resources together. Critical, bringing the region together, having common policies, and working together on behalf of our patients. Improves the application of guideline recommended care that we all strive for, and promotes regional STEMI systems of care implementation efforts, again, through data collection, analysis, and collaborative quality improvement activities, really the foundation of Mission Lifeline, and much, much more. So clearly a work in progress. We are looking forward to working with you to be helpful in any way we can, and to sharing our progress in the years to come. So thank you very much.
Thank you, Dr. Ellis, for the nice presentation, and it is very informative. Let's see if we have any questions. So just a reminder again for everyone, if you have any question, please drop it in the Q&A, and we'll be more than happy to pull them up and ask our speakers.
So right now there's right now there's no questions, but I actually do have a question for Dr. Jacobs. So, you know, we know that at a hospital level, as any hospital thinks about becoming a primary and or comprehensive chest pain center, some of the foundational work is, you know, bringing together all the internal and external stakeholders. Could you just highlight for the group, Dr. Jacobs, a little bit of sort of a listing, if you would, of some of those internal stakeholders and the external stakeholders that a hospital would want to bring together to start the conversation around establishing themselves as a chest pain center and being able to serve their community in the management of the STEMI patient?
So thanks, Louise, for your question. I think that, you know, you need to bring the STEMI system components together. So when we first launched Mission Lifeline, that was our vision, even with recognition that we would recognize hospitals and we would recognize EMS, but really what we wanted to do was recognize the STEMI system. So to make hospitals responsible for each other, the referral hospital and the receiving hospital, if you will, working together. So it's really bringing those components in the community together. And it's, you know, your transporters, your EMS, your payers, if you will, your caregivers, your, you know, patient representatives at the table together to try to agree on protocols to enhance care and improve the quality of life. So it's really the community that you want to bring together that is involved in the care of STEMI patients.
Thank you, Dr. Jacobs. A question just popped up, and it's a little bit, sounds somewhat quite related to what you were just describing, which is how things should go as regards to community awareness. So I think that, yeah, go ahead.
Go ahead, Louise. Go ahead. You can, I know you can answer that just as well.
Well, no, I was just going to say, I think this is about, you know, how to, you know, there's work at the hospital level, but there's certainly a level of community awareness. So, you know, have there been any campaigns or special initiatives around or efforts around STEMI systems of care that have helped the community to broaden their understanding of the importance of this work?
So, you know, at the outset, that was a huge challenge. There were a lot of community-based initiatives and public awareness campaigns in the early days that really didn't move the needle. More recently, there are pockets. Minnesota is one. Minnesota in the South, in California, in Los Angeles, we're making some progress, but it's really been it's really been a challenge for us. If you look at the progress we've made it really in most of the silos in the hospitals and the referring hospitals in the system, but reaching the patient, decreasing the time that the patient takes to call and activate the system, we are not as successful in. And so AHA now has, a Don't Die of Doubt, different campaigns where we're targeting different ages and races and ethnicities with our messaging. The other thing that when we started, I think it was 60% of patients brought themselves to the hospital and 40% dialed to EMS. And now that's flipped, but still it's not nearly where we need it to be. So really getting to the community and getting to the patient and getting our word out is a challenge that we continue to work on and collaborate, with the CDC and other organizations to help us with that. But it's very, very critical and very important.
Thank you, Dr. Jacobs. And, the region in the Middle East will be learning a lot and continue to learn from our experience in the US. So thank you so much for your leadership in this space. And right now, that's the last question that I can see.
Thank you, Louise. So thank you, Dr. Alice. We'll continue with introducing chest pain center certification with Mr. Muhammad.
Thank you, Rami. Assalamu alaikum, good evening. I would like to talk about introducing the chest pain center certification in the Emirates mainly. Since Emirates is the first country to initiate this program in it, maybe it's a start to share with you the news about the American Heart Association and the Emirate Cardiac Society collaboration. Recently, last January, the AHA signed a memo of understanding with the Emirate Cardiac Society on January. And this collaboration aims to improve and advance the care of the acute MI. And we would like also to thank the Emirate Cardiac Society, represented by the President, Dr. Abdel Majid Al-Zubaydi, and the board members, in addition to the working group, for their commitment and efforts that they are putting to improve the care of cardiac patients in Emirates. And the start is to talk about the certification review process. It's a very organized and structured process, starting from the initial readiness review. This will help to conduct an initial self-assessment of the chest pain program by the AHA and MENA program team as well. And the second step will be the desk review. And this stage, the documentation, the data, and the evidence of compliance reports and other documentation to support the certification process. All the documents will be submitted by the hospitals, and it will be reviewed by the AHA experts. So they are trying to look at the compliance and other data. And if they found that there are areas for improvement, this is the time that we are going to arrange such like a virtual meeting to resolve or discuss all these issues and to be managed in a proper way. Then the next step, it will be the virtual review. And this step, the virtual review is a consultative process actually, and in fact it helps a lot that both sides, the AHA reviewers, they can meet the hospital team, including the chest pain program team, in addition to the director of the program, the coordinators, and the interdisciplinary team. And during this meeting, the AHA review experts will allow for formal validation of the high quality standards and established prior to receiving the certificate. And they can also identify all the areas for improvement and the opportunities to improve the system of care. And the next will be the certification evaluation review. This is very important since the hospital will submit after submitting all the required documents, the reviewer will submit a detailed report to the certification review committee for consensus agreement. In this stage, the report will include, but it's not limited, of course, to providing a feedback on the KPIs and the action plans, if there is any. And then the evaluation report and on the ongoing communication, and then the final review or passing report desired to be as fully compliant as possible. The final approval decision may include a condition of an action plan as determined by the committee based upon the gap identified. And at the last, of course, we need to make sure that this is a sustainable, continuous culture to maintain the compliance of the standards. So the annual review will be for maintenance of certification to provide updates on the progress from recommended opportunities for improvement from a previous review, along with the ongoing reporting assessment of the quality of metrics. So the annual maintenance is mandated in our certification. And the next slide shows simply all the steps for the reviewing process. And then next slide, please, Khaled. Yeah. Now, in this slide, it summarizes the process, how it goes. First of all, the hospital will apply to join the certification program. They should complete the application form in addition to the participation agreements, the one for the chest pain center certification agreement, and the other one to join the coronary artery GWTG guidelines agreement. Then after that, they have to submit the fee. Then this is the time that they get involved in the program, and they start to submit the documents. And the abstractors now entering the cases through the coronary artery disease GWTG guidelines. And as we mentioned before, the data will be reviewed by the expert, the AHA reviewers, and then the decision will be made to issue the certificates if there is a compliance with the standards. Next, please. I'll talk about the program eligibility criteria. So who is eligible to be involved, or who can join our program, in fact? Actually, there are two steps to get involved. First of all, the hospital should be get involved in a coronary artery disease GWTG guidelines registry, or a national or international another STEMI or acute coronary syndrome registry tool. And in addition to that, the comprehensive cardiac center, the receiving centers, must perform a minimum 150 total PCI procedures and minimum of 36 primary PCI procedures over the most recent 12 months. And I'll talk more about the criteria. And as you see here, this slide, it shows exactly what is required for each program certificate. We have two program certificates. The first one is comprehensive chest pain centers, and this is for the receiving centers who are performing the PCIs 24/7. And as you see, there are certain criteria for the comprehensive centers. For example, the protocols for triage, diagnosis, and treatment for the chest pain patients, and the other one on the on-call cardiac cath lab 24/7, regardless of the ER version, and other criteria as mentioned here. And there is also a special criteria for the primary chest pain centers or the referring centers, as you see it here. So through this, the centers or the hospitals in advance, they can identify the readiness to which program they are eligible for and which one they can apply to. Next, please, Khaled. Yeah, now I'll talk about the standards. The AHA provide an organized, a clear standards manuals. This will help the hospitals to go through and to follow and implement as well the required standards to achieve the certifications. In this manual, there are 6 chapters, including the program management. In this category, the hospital should show that there is a systematic oversight of the chest pain program, and there is an identified chest pain coordinator, in addition to a medical director or a physician champion who's leading the whole program in the hospital. And they should identify the interprofessional committee. And if we move to the next one, the other standard or the other chapter, which is the healthcare professional education and the competences. AHA as well also identify the required competences and the education programs required for each staff are involved in the certifications, like the physicians, the ER nurses, for example, the cath lab nurses. And the hospital should show that there is an educational programs and competences for the team involved in the certifications. Then the patient caregiver support and education, which is a very important chapter which reveals that the patients and the caregivers are getting enough education in terms of cardiac care pre, during, and after the hospitalization, and even the rehabilitation as well. And the next chapter is talking about the care coordination. There must be also, again, a STEMI unit, for example, and a STEMI team identified, for example, to handle the cardiac patients. And then the clinical management, which shows that all the management or all the interventions and procedures based on the latest clinical evidence-based clinical guidelines. And at the last, the quality improvement and the KBIs needed to monitor this program. Next, please, Khaled. And this is about the KBIs for certifications. In addition to the previous standards and the compliance of the previous requirements, hospital, there are two, again, there are two certifications for the comprehensive and the primary chest pain centers. And there are identified and required KBIs for each one of these centers. So there are 3 for the comprehensive centers, and there are around 4 for the comprehensive primary centers. Again, these KBIs, in addition to the previous standards, it doesn't stand alone. Thank you. And I think last thing is the DHA staff support to make sure that the hospitals who are involved in the programs are well guided and well advised. So the DHA staff support offering the following services and the following support. The first thing that we have to make sure that our hospitals are really aware and familiar with all the required standards. So there will be an international and local clinical expertise who is dedicated to advise and to support and to give all the help as needed when it is required for the hospitals. In addition to helping to conduct hospital gap assessments, so we have designed well-structured baseline assessment tools. We can share it with the hospitals so they can identify their areas for improvements, and we work together with them to get the better results. Next slide, Khaled. And the last thing I would like to share with you is another providing templates. We really do this in terms of providing you with all the quality plans and other educational resources, which will help really to go through this certifications with confidence and with no hesitance at all. And the last thing, we have a website, which is the QI website, where multiple resources like education and best practices are open to the public. And again, we will be happy to conduct later on any meetings with you to give you more information about the certifications and what really will help you to be confident to join our programs. And thank you. Thank you, Ram.
Thank you, Muhammad. Thank you. So just a reminder again to write the questions in the Q&A, not the chat box, please. And we'll continue with Ms. Lori. Can you hear us, Lori? You are muted. You are muted, Lori, sorry.
There we go.
Yeah, sure. Go ahead, please.
Okay, can you see my screen?
Yes, yes.
Okay. All right, so thank you, everyone. And it is really such an honor to present a brief demonstration of Get With The Guidelines CAD. And really, it's a cardiac registry. We're not going to go into the actual patient data entry, but what we're going to do is just demonstrate a few of the tools that can be used to support the certification efforts and continued STEMI systems of care adoption and optimization. So what we're seeing now is a case list of the patients that have been entered, and this is a demonstration facility. So this is all made up data, made up, but with thought to, to demonstrate the measures that would be used for your certification opportunity. So what we would do is once the patients are entered, we want to look at our data. We would go to the operational reports. There are several operational reports to choose from. We're going to focus on the measure reports and advanced analytics today. There's so much we could talk about. I'm sure we could take another hour to look at all the data and all the reports. We are able to select your reporting periods. So you can choose from annual, quarter, monthly, and even daily if you're a high volume facility. So for this demonstration, we're going to choose annual, select annual. And I know we have patients that have been discharged in 2021. So we're just going to do year to date. Now, at the bottom, these are 17 different measure groups. And I guess we could open up a measure group. These are the measures that are used for hospital recognition, for STEMI Receiving Center or PCI Center recognition. And we could open up all of these. Some are repetitive, some are just reporting measures not used for recognition. But since we're talking about certification efforts, this would align with, I believe, the comprehensive certification program. So we're going to look at our, actually the primary heart attack. So we're going to look at this measure group today. So I selected the entire measure group, and you could select your hospital to look at your hospital data, but there's also opportunities to select from different benchmarks. For this demonstration facility, we only have all hospital benchmark, but as hospitals adopt Get With The Guidelines CAD use, we can create different benchmarks regionally, nationally, by PCI facility, by bed count, several different models to benchmark against. Another feature of Get With The Guidelines CAD is, in addition to running measures and benchmarking yourself against other facilities or other measure groups or other benchmark groups, is that we're also able to filter data. So we're just going to add gender as a field that we want to filter by. Now, these reports can be saved so you can access them as run at a future date, but today we're just going to apply the parameters and generate the report. It does take a second or two to run since we're running some national data, but as the data is loading, first you will see your hospital data, and then we will see the national data. So my hospital data is in red. All hospitals, the national benchmark is in blue. Now on the left-hand menu here, we can open up our primary heart attack center measure group. And if we want to eliminate one of the measures, we can. So let's eliminate the arrival at first facility because we don't have any transfer patients to date in this facility. So now we can see just the data for the 3 measures. So this is your graphical display of data. Remember, we selected gender as a filter group. So I'm going to select gender in the comparison variables, and now the data is displayed with female on the left and male patients on the right. So now we can see the difference in process times and adherence scores by gender. Now, although this graphical display is nice to look at, it's somewhat difficult to really get granular with the data. So we've provided tools to be able to get a little more granular in the data. So at the bottom of our display here, we're going to select measure details, and this will produce a table of our data. So now you can see the benchmark group on the left, all hospitals, and it is divided by gender. So female, male, and then our measure group and the measures here in the middle. Your time period is displayed, as well as your total patients for the nation, and then your total patients for your hospital. Now, as we're looking at this data, I am seeing, let's open up the measure description a little bit so we can see that a little better. I am seeing that we have a score of 66.7% at the very bottom row. So this is primary PCI in 90 minutes or less. So let's dive into this 66.7% because we really don't expect it to be that low. So we would highlight any number in this row, and as you highlight the number, it turns the row blue. Once the row is highlighted blue, we go to the bottom and we select case list. This takes us to exactly what it says, a case list of patients that not only fall into the denominator, but are, it's the entire case list for that time period. But what I just did was I filtered by denominator. So my denominator patients are on top of the case list. The numerator patients are showing, and then we have our one patient ID 1234 that fell out of the numerator, and we show one patient with an exception. If you scroll across, the majority of the data elements that feed into this measure are provided for at a glance observation, so that you may be able to just identify an issue or why the patient was excluded or why the exception was applied at a glance. But for this patient, I'm not really understanding why the patient fell out of the measure. So again, we want to look for trends, especially as we go through our process opportunity efforts and collaborative efforts with EMS. We want to look for trends in our data. So we want to investigate why this patient fell out of the arrival to PCI within 90 minutes. This access care column, once we click access care, it takes us right to the patient record. So this way we can identify, we can go through the patient record and we can see if there are any issues that we can address just by looking at the data entered. Now, the one thing that catches my eye in the patient record is the right-hand tab. The hospitalization has an X marked by it, as well as it's colored in a golden orange color. So that means there's some sort of data that might be missing or an issue with the data. So I'm just going to click on that and open up the checklist. So this tells me that we did not document a reason for not entering thrombolytics. So we see this right in the middle of the screen, reason for not administering thrombolytics. This does not really tie into the measure per se, but it does affect the record not being complete. So this allows me the opportunity to complete the record. Now I have no outstanding task. But as we're looking through this record, we can see that the cath lab activation time was 1:20. I want to go back to look at, and the first EKG time was 12:09. So it took 71 minutes from the time we noticed a STEMI on the 12-lead ECG to the time the cath lab was activated. So that's something to dig into a little more, that it could have been an issue of a system, non-system reason for delay not being documented or just not being abstracted. So if there was a non-system reason for delay in this patient, such as maybe the patient went into cardiac arrest, if we selected cardiac arrest and resubmitted this chart, reevaluated the data measure, this patient would now be an exception to the measure and not be included in the denominator. So again, this is a very brief, very short demonstration of how Get With The Guidelines CAD can support, looking at trends over time, but also support diving in and doing patient level detail analysis to see why the guidelines, why the patient fell out of the guideline therapy. So I do want to go through, let's save and exit. I want to go through one more, if we have time. one more report, the Mission Lifeline Advanced Analytics. So this is, you heard Dr. Jacobs mention our regional efforts. So this is the regional report. And, you know, this really allows hospitals, once there are more hospitals participating, it allows hospitals to blindly share their data in a region. So it compares the region, the nation, to hospital to hospital to hospital comparison within the region. And again, this is blinded data, so only you know your hospital's blinded identifier. Other hospitals are not aware of your identifier. But it gives, and this does take a second to run, but it does give you an opportunity to look at additional data besides percent adherence to measures. It provides median times for processes, like median time from STEMI notification to STEMI activation. So EMS notification to the emergency department to the time the emergency department or cath lab activates the cath lab team. It provides median time door to balloon. It provides median times of symptom onset to PCI. So there are lots of median times that are available here. And again, you can select benchmarks to benchmark against, as well as see your own hospital's data. And you can also select the time parameters that you want to view. You can view it by quarter, you can view it by year. We're also using this area to test providing additional data, such as percent arrival to PCI within 60 minutes, because we hear that 60 is the new 90. So we want to look at that data. And here in the arrival to perfusion category, you can see the median time from arrival to PCI for my hospital is 79 minutes, but for the nation it's 62. So my hospital has a little bit of opportunity to improve. Now we're going to look at median time of arrival to primary PCI in less than 60 minutes for females. So, you know, 70 minutes for females, 93 minutes for males, and then percent arrival to PCI within 60 minutes overall. So in addition to that great table data, there's also graphical displays of data. And again, if there were more hospitals in this demonstration region, we would see more bars displayed to the right. So what we're seeing is a national benchmark comparison on the left, and this is percent arrival to primary PCI in less than 90 minutes. Green is our EMS population, red is our walk-in population. Now, again, we can expand and look at the table data a little more. If we close that back up, I can select a patient row, and the case list, as we saw earlier, will be shown underneath. So again, you can filter, sort by denominator, so that you can see the patients that fall into the regional report and the patients that also fall out of the measure. I'll just show you a couple of the graphical slides. So median length of stay in the emergency department. Again, this is very critical, you know, when we're looking at mortality, lowering the length of stay in the emergency department is very important. So for EMS, we have our hospital has a long length of stay for EMS and a shorter length of stay for walk-in patients. We would expect that to be reversed. So again, this is an opportunity to improve our relationship with EMS. And as we're looking at our certification process, you know, working with EMS is going to be very important in making sure that we improve those processes with EMS. It's going to be a great discussion at the table, you know, in the in-person review for certification.
Thank you, Lori.
Yes, do I need to stop?
Because of the time, if there is something you want to add, so before we move to Loni, she will re-emphasize what you have said and show them more details if you don't mind.
Oh no, absolutely. Like I said, we could go on a long time with the demonstration. So happy to stop here, and if there are any questions, I can take them after or offline. But thank you so much.
Appreciate it. Thank you. Loni, the mic is yours. You are muted.
Thank you. Thank you, Lori, for that great
Yes.
demonstration of the tool. Lori and I are in the tool every day. We love it. It's a great registry and resource for our hospitals and our systems of care work. So I'm going to just very quickly go through how the registry can be used, a variety of ways that it can be used. We have 430,000 patients entered into the registry. It supports internal hospital process improvement for heart attack patients, but also supports our regional system of care quality improvement activities. Real-time reports, Lori demonstrated. We have real-time feedback reports, which are so useful in getting information back to our referring hospitals and emergency medical system providers. And it can be used for research. And then, of course, it's required for your journey to chest pain certification or cardiac certification. So this is just an example of each of the measures match the guidelines. So this one is arrival to 12 lead ECG within 10 minutes. This is an example of how you can track your performance. This is a quarterly snapshot. Next slide, please. This one is a monthly graph. So you can see how very quickly the registry helps you identify if there's an issue. This one is EMS to PCI within 90 minutes, the percent of time that the patients fell into the measure, and just helps to identify when there's a problem and so that correction can be made quickly. Next slide, please. So this one is an aggregate data for an entire region, and it's a way for a region to monitor trends over time. This one is EMS to PCI as well, quarterly, which is so helpful when our systems of care are all working together on protocols and making modifications, system-wide modifications. Next slide, please. This is an example. This is what Lori was talking about. If you have an entire system participating, the graph or the column all the way to the left is aggregate data for the entire system. And then each column to the right represents a hospital in that system, blinded, of course, by number identifier only, so that it allows just really great benchmarking between hospitals in a region, and then the region to other regions. Next slide. This is my last slide. This is just an example of how the registry data has been used for research. This was a publication in Circulation, and it's regions across the United States that implemented systems of care work, such as what Dr. Jacobs described in her presentation, and how we saw improvements and changes over time, and this allowed that benchmarking to happen, and then ultimately resulted in the publication of the research. So that's it for me. Do we have any questions?
Thank you, Lonnie. Thank you for the informative presentation. So we'll have time for the questions. If anyone have any question, we'll be more than happy. Our speakers will be more than happy to answer it.
Right now, I think some of the questions we've taken care of that were more specific to a site. I don't have any general questions, Rami.
Thank you, Luis. Thank you. So we hope that everything was clear and everyone got the benefit from the webinar. So our speakers, Mrs. Zahra, Pooja, Luis, if you have any final word to our attendees, go ahead, please.
Thank you so much, Rami and team. It's amazing work that you have done, and looking forward to more webinars and participation from the region. Thanks.
Thank you, Mrs. Zahra. Thank you for your attendance, and we hope that you got benefit from our webinar for today, and see you in future webinars, inshallah.